Good afternoon, everyone, and welcome to this session, Multi-Cancer Early Detection, What's Happening and What's on the Horizon. My name is Hillary Robbins, and I'm an epidemiologist at the International Agency for Research on Cancer in Lyon. I'll be opening this session by giving a very quick overview of the landscape of multi-cancer early detection tests and their potential benefits and harms. Multi-cancer early detection tests are tests that use a single, easily obtainable blood specimen, this is almost always blood, to screen for more than one type of cancer at the same time. The analytes measured by multi-cancer screening tests are most frequently methylation of circulating tumor DNA, but they can also be DNA mutations, microRNAs, proteins, and other analytes. Some of these tests predict the cancer site of origin. So when the test is positive, the test will say it's most likely in, for example, the colon, but other tests do not give any such prediction. Multi-cancer screening tests are different from standard single cancer screening in a few important ways. On the side of potential benefits, of course, multi-cancer tests can potentially detect types of cancer for which we have no standard method for screening. They do this with an easy and simple blood test, looking for multiple types of cancer at the same time. And there's evidence that these tests can potentially avoid overdiagnosis because they are unlikely to detect indolent cancers. However, there's also new scope for harms with multi-cancer screening. These tests are looking for a cancer that could, in principle, be anywhere in the body. So when the test is positive, and we look in the most likely place, and then we look in the second most likely place, and we don't find the cancer that we're looking for, it's very difficult to say at which point we are finished doing diagnostic procedures and we can tell that person with confidence that they don't have cancer. We're also concerned that there could be false reassurance for the idea of any cancer, so that someone who has a negative multi-cancer screening test might assume that it's impossible that they have cancer. They could potentially ignore potential cancer symptoms, when we know from the evidence that we have at hand that it's not at all true that they cannot have cancer. And finally, on the health system side, some of these tests are very expensive. They cost up to $1,000 per person per test per year. And so these costs could add up very quickly for health systems. The U.S. National Cancer Institute published earlier this year a review of the current landscape of multi-cancer screening tests. At the bottom of this figure is the preclinical exploratory studies phase of research, and it's essentially impossible to count the number of tests that are in this phase. At the next level of evidence, clinical assay development and validation, there are many tests at this stage. And then next, in retrospective longitudinal studies, there's a number of tests that have reached this phase as well. There are 2 tests that have reached the phase of large prospective screening studies, and currently no tests have published results from large randomized controlled clinical trials or from community use. I'll talk in a bit more detail about the 2 tests that have been studied in large prospective screening studies. In 2020 in the journal Science, we saw the results of the first large prospective multi-cancer screening trial, which was the DETECT-A study, which used the CancerSeq test from Exact Sciences. The DETECT-A study enrolled 10,000 women aged 65 to 75, and a single test was done at baseline, and then the women were followed up for 12 months. Everyone with a positive result was referred directly to PET-CT for workup, and at the end of these 12 months, the specificity of the test was 98.9%. The sensitivity was only 27% for the cancers developing over the year, and the positive predictive value was 19%. That is to say that among those with a positive test, 19% had cancer by the end of the year, and the other 81% seemed to be cancer-free. Among all participants, 0.22% had a fetal invasive procedure, so an invasive procedure but no cancer found. At the end of last year, we saw the results from the Pathfinder study published in The Lancet. This was applying the Gallery test from GRAIL. The Pathfinder study enrolled 6,600 people aged 50 and older with the same design, a single test and 12 months of follow-up. The Gallery test predicts the cancer site of origin, so it tells you the first most likely place in the body that it thinks the cancer is, and then the second most likely. And these results were given to physicians, and physicians had the liberty to choose the diagnostic follow-up procedures. At the end of the 12 months, the specificity of the Gallery test was 99.1%, the sensitivity was 29%, and the positive predictive value was 38%, with fetal invasive procedures in 0.26% of all participants. The accuracy of either the first or the second prediction for the cancer site of origin was 97%, although this included one positive result for which the cancer site of origin was indeterminate. So if we put these results next to each other, Detect-A with CancerSeq on the left and Pathfinder with Gallery on the right, the specificity of these tests at 12 months was almost exactly the same. The sensitivity was almost exactly the same, and the harms, as measured by fetal invasive procedures, were almost exactly the same. The positive predictive value was a bit higher in the Pathfinder study, although more than half of the participants had additional strong risk factors for cancer, so this is likely a function of the baseline risk. And so in sum, we see quite similar performance of these two tests that have been studied in depth thus far. Multi-cancer early detection tests are extremely controversial. There's a number of different reasons for this. In the US, there are a handful of tests that are marketed now, although they are not FDA approved and they are not covered by insurance. So it's a real challenge for primary care providers to communicate to people who are interested in these tests and asking whether they should perhaps spend $950 out of pocket for a test. In the UK, there's been a large randomized clinical trial implemented, and there's a lot of discussion about the endpoint of that trial and how the evidence should be used. So these are some of the topics that will be addressed in the talks to follow. I'm not going to introduce each speaker individually so that we can save time for hopefully 12 to 13 minutes of discussion at the end, so please write down your questions. Following my talk, I will pass the microphone to Dr. Lori Manassian from the US National Cancer Institute, who will talk about the context of multi-cancer early detection in the US. We'll then pass the mic to Richard Lee from the UK for the same story about the United Kingdom. Following that, Dr. Hashim El-Ghazali will discuss whether multi-cancer early detection tests should be considered for use in low and middle income countries. And finally, Ruth Etzioni will discuss how we should evaluate the clinical utility of these multi-cancer tests. So with that, I will hand it over to Lori.
Thank you, Hillary. It's a pleasure to be here. I am a medical oncologist and the Deputy Director for the Division of Cancer Prevention at the National Cancer Institute, an institute part of the National Institutes of Health in the US. It's a pleasure to be here, and I have no conflicts of interest to disclose. So in the US currently, there are several single cancers for which we have recommended cancer screening. The cancer types in particular are breast cancer, which you're all well familiar with, mammography, cervical cancer with pap smears and HPV testing, colorectal cancer with several different tools, including colonoscopy, the FIT tool, stool DNA, and others, lung cancer with low-dose CAT scans. Each and every one of these recommendations is the result of large-scale randomized controlled trials, which were pivotal in showing that using these tools specifically for screening asymptomatic individuals would in fact save lives from those specific cancers, and that the benefits to using these tools would outweigh the harms. In addition, through these trials, there were also additional information that was provided on how best to use these particular screening tools, what the incidence of false positives and false negatives were. In the US Preventative Task Force is the independent panel of experts that is tasked with reviewing all of the data in order to make those specific recommendations. And this is a panel that's empowered that are primary care and prevention scientists and public health scientists involved. And as you can see here, this is just one example. There are over 11 randomized controlled trials in colorectal cancer screening, and there is sufficient evidence to even stratify the recommendations based upon age categories. The current status of multi-cancer detection assays in the US is that none of them have formal marketing approval through the US Food and Drug Administration, and yet there are 3 commercially available assays. Currently, there's no reimbursement of these tests for cancer screening by US government health programs, nor do we see any private payers paying for the test. Some of the private payers are in fact paying for bits and pieces of the diagnostic workup, but it's not always clear. And in a recent paper published surveying 19 private payers in the US, none of them reported covering multi-cancer detection assays, specifically citing the fact that there was no definitive evidence to show that it benefited people. Thus, there are no clinical practice guidelines that have been issued by any of our medical societies or the US Preventative Services Task Force. So that puts us in an interesting position. We are all looking globally for new ways to screen for different cancer types, and the idea and the concept of a blood test that can screen for multiple different cancers is a very enticing concept. Everybody would love to have a simple way to detect multiple different kinds of cancers. However, there are many unanswered questions in the use of these blood assays for cancer screening. First, what does a positive test mean? And we've started to have surveys and a look at both primary care physicians and laypersons' understandings of this. The MCED tests are not diagnostic. A positive test does not mean you have cancer. What it does mean is that the test has a signal that you may have cancer, and that starts a series of additional tests for the diagnostic workup. The diagnostic workup actually varies by MCED tests. There are 2 primary ways to do this. In the case of an MCED that provides you with a tissue of origin, they'll give you a positive MCED assay and say there's a 70% chance that that signal comes from breast, or that signal comes from GI or some other location. And in fact, some of the tests will give you the first most common, the second most common, and maybe even the third most common prediction for where the signal is coming from, and that helps direct the clinician down the road of what diagnostic tests to perform. When there is no tissue of origin recommended, then the next step is usually an imaging modality. And often it's a PET CT scan, which are not commonly available in every geographic distribution. And then the PET CT scan gives you an opportunity to follow whatever abnormality is found on that. So in compilation, there's a series of unanswered questions. These are just a handful and at the top of our list currently. How many and what kind of diagnostic tests are needed to actually make the cancer diagnosis? How many people will be subjected to unnecessary invasive procedures and suffer from various complications of those procedures? What happens after a positive MCED when you don't find cancer? And how many of the predicted signal types how many of the tissue of origin types do you follow before you decide you have a negative test? Will people with a negative MCED test then forego doing the recommended cancer screening? Will a blood test actually make screening more accessible, or will it make it worse because you don't have access to the diagnostic workup? And whether or not these assays will lead to overdiagnosis of indolent or slow-growing cancers. So this tidal wave of technology that is coming down the path is already out of date. This tidal wave was made about 2 years ago, updated about a year ago, and already the technologies and the companies are rapidly changing. But you get the idea that there are many more coming down the pike, and the clinicians and the patients have the opportunity to be inundated. What we have done is we have started a process to explore and consider what clinicians and what laypersons are thinking in this space. And what we're seeing is our primary care physicians are very unsure about how to use these tests. Here are two quotes from primary care physicians. We're doing a blood test. We don't know what it means. We don't know what a positive is. We don't know how to act with a negative. Sometimes one test leads you to other tests, and then you're kind of chasing down a rabbit hole, trying to figure out what it means and what's really important. So there's a lot of concern, even though the technology holds a lot of promise. We've started a brand new cancer screening clinical trials network to evaluate these technologies and other technologies that will be coming down the horizon, because we believe that there is no one technology, but a series of technologies that will be needed to screen patients for cancer. So we launched our new network in February of this year. We are actively engaging different MCED developers in the process, and we are collaborating with other U.S. federal agencies. We are very fortunate to have the investigators from the Fred Hutchinson Cancer Center, and you will be hearing from Ruth Etzioni later as one of the PIs in our network, as well as multiple sites across the U.S. One of the key things that we asked our accrual sites to do was make sure that they had outreach to underserved populations so that we could make sure that the results of our studies are as generalizable as possible. The first agenda for this new network is the development of a large pilot study that we are calling the Vanguard study. We anticipate now that we will randomize about 24,000 persons to 3 different arms: a control arm, one arm that will have one MCED intervention, and a third arm that will have the second MCED intervention. And this would be an opportunity to evaluate those in the control arm that aren't being evaluated for the MCEDs. We will capture all cancers on all patients, to be better able to understand how this is working, how successful there are, and hope to answer in particular questions about the diagnostic pathway. In summary, these tests have enormous potential, and the technology is rapidly changing. We do need more clinical trials, and we do need randomized clinical trials to better understand the risks and benefits so that we can answer some of those unanswered questions and realize the full potential of this potential technology. Thank you.
Thanks. Thank you for attending. I'm going to talk about the situation in the United Kingdom. So my name's Richard Lee. I'm a pulmonologist from the Royal Marsden Hospital in London. These are my declarations. I'm going to spend a lot of time talking again about this GRAIL gallery study. I have no relationship to either the study nor to GRAIL. So I think it's important to think about what is the context of the cancers that you're trying to diagnose with these multi-cancer tests. So as an example, this is the UK data. We can see on the x-axis the proportion of cancers diagnosed at an early stage for these cancer types, and then the number of cancers. So you can see the really big common cancers at the top of the graph. We can see the established screening programs for things like breast cancer. Perhaps an MCED might not be so helpful in that setting, or at least it needs to exist comfortably alongside the screening program that's already diagnosing patients effectively. We have an evolving screening program for lung cancer, but these early stage rates are very low at the moment still. And then we have these other cancers which persist in being a problem. There are smaller numbers in terms of those that we might expect to find in the population. And this is the goal that we're aiming for as a national target, 75% at an early stage. So the NHS Gallery study essentially has come about as a way of trying to tackle this long-term plan. It's a collaboration between the National Health Service and the company GRAIL. And essentially what they've tried to achieve is, instead of undertaking a clinical trial that's based more towards mortality that you might typically expect for a screening study, they're looking to see whether the surrogate outcome of a stage shift could give rise to a kind of a real-world demonstration project or implementation, and that's being funded by GRAIL. There's been various experts consulted in the process. There's full research governance and other governance behind this. And the goal at the end of this, if an initial appraisal of the data, not an interim analysis, but a viewpoint on the data that's been seen, is aligned with what was expected, then it would be rolled out to 1 million patients between 2024 to 2025 at a pre-agreed price. So this has caused a lot of excitement. The trial in itself is a randomized trial. You can see on the right of the slide that there's a control group in the light blue. Those samples are just stored, so they will be there for future analysis, but they won't be looked at now. Then you have the test group. The patient will undergo the testing. If they have a positive signal, they'll be informed, they'll be investigated. If they have a negative signal, that result is not shared at this stage. So already 140,000 patients have been recruited, so we're now in the observation and follow-up stage of the trial. It's a massive study. I think the investigators are to be commended for the scale at which they've achieved this and the speed. They've used a dedicated research digital infrastructure, and they are active across 150 sites, 11 mobile clinics, and 45 languages. Essentially, they are trying to mimic usual NHS or National Health Service pathways. So the purple-grey, again, slightly to the right, is what might normally happen. So if you had a diagnosis through an existing screening program, that would go into an NHS referral. If you had a symptom, you might go to your GP. The GP would assess and consider investigations and then refer into the hospital service. So the green boxes represent how the Gallery study tries to replicate that, and you either refer directly into that cancer pathway, or you have a local champion at the receiving hospital to say, well, this is our usual pathway, and they will triage the referrals coming through. There's consideration of safety netting, so trying to think, could we lose a patient with a positive signal? What at the trial level and what at the receiving hospital level will be in place to prevent that from happening? In consideration of that 1 million patients or participants, there's clearly a lot of preparation work is needed. So we have to think about local and national communications, about what's going on, what it will mean at the hospital level and at the participant level, thinking about the scale of administration, of the IT capabilities, of the phlebotomy or blood-taking capacity, thinking about all that laboratory capacity, all of the training of staff, all of those downstream referral pathways for every single cancer, for every single hospital site that might receive one of these referrals. The sheer scale of this is pretty huge. And so sort of thinking about what might be expected, there's a lot of consideration about tracking the delivery of this study and thinking about what happens if we proceeded to a 1 million patient rollout. So the goal has been essentially to do that before the trial has finished. So that has attracted some criticism, as Dr. Robbins, my colleague, indicated. The initial stage is being supervised by 8 of these Cancer Alliance networks. So if you look, there's a regional structure where each of these dark blue boxes is an area of the country that is focused on cancer innovation. And each of these alliances has been given the remit to oversee how this study is being delivered, with a plan that next year, or sort of part of this year, the other alliances could then scale this up in the same way to the 1 million participants. Now, already these alliances that haven't yet got the Gallery study have begun to do that work. They've been thinking about those relationships with the phlebotomy centres around them. They've been talking to the local hospitals, doing the communications work, drawing in clinicians. So there's a huge amount of work that's been underway to try to think, okay, if this study came to us and was effective, what would we do? Now, obviously, that has costed funds. I understand several £100,000 per area, UK pounds. And I guess there's an interesting philosophical question there about the kind of understanding the value for money of that work. But there has been that learning in that preparation. I guess, unfortunately or fortunately, depending where you sit on the argument about whether this was the right approach, a preliminary analysis has essentially said that the trial is not yet ready to convince the National Health Service that this 1 million patient rollout should go ahead. You can read the detail of that on this blog article by one of the national cancer directors with the link at the bottom here. But essentially, what we're now seeing is the trial will continue to try to understand the data, but that implementation effort will now pause. I think it's a good moment to take stock of what happens in other screening programs. So this great diagram about lung cancer screening essentially shows you individual avatars for all of the people that take part in a lung screening program. Now, bear in mind, we know we've got evidence that lung cancer screening reduces lung cancer and all-cause mortality, which we do not yet have for multi-cancer blood tests. All of these people will have their scan and will go away healthy until the next screen. All of these will have an indeterminate result. You could call this a false positive, or you could call it an unknown, and they will need a further scan within a short period to further investigate something. So I guess you're thinking here that's not that dissimilar to a positive cancer signal blood test. These people will have a lung cancer diagnosis. These will have a change in their mortality for the lung cancer diagnosis, and there's a few people here that will be overdiagnosed. So we really need to start to think about these multi-cancer tests in terms of these kind of ratios. The other thing we've seen, now my day job is lung cancer screening, the other thing we've seen is you scan a patient's chest, you're going to find a lot of emphysema, you're going to find a lot of coronary artery disease. And when you send that back into primary care, you're creating a lot of work, you're creating a lot of expense. Now, we've managed that very carefully, and we have a very positive relationship with primary care. And we can imagine that the blood tests will essentially do a similar thing. They're going to find things that we're not expecting in terms of cancers or pre-cancers potentially, or kind of alternative findings that we really need to think about what might we see and how might that be managed. And I think we can also anticipate where this might work and where it might not work. So there is data out there that tells us about how these tests performed in some of the early studies. If we went looking for a stage 1 lung cancer with this blood test, we might struggle, whereas there are other cancers where we find very difficult to diagnose where they might be more effective. The other thing to note is there is data that suggests if you compare these survival curves, the blue patients versus the red patients are the cancer signal positive patients. So across all stages of disease, you can see that the cancer signal positive patients, so a positive blood test, they have a worse outcome, so worse survival purely because of detecting that DNA or other signal in the blood. So again, we need to think about what does this mean for the potential mortality benefit of a multi-cancer blood test. It's a good opportunity to think about patient experience, participant experience. I won't go through the detail of that now, but essentially doing this I think is great from the opportunity to do implementation research around this. And it's also an opportunity to think about what would symptomatic patients, where would they fit into this? So in summary, I think it's a great opportunity. I'm not involved with this, but I've seen some very positive engagement of the community. We still need more data. These are essentially still research tests. There's a huge amount of hype that we really need to get to the bottom of the science, and we need to wait for that further data to come through to understand what this means. I'll stop talking there. Thank you very much for listening.
It's okay. Thank you. Okay, thank you very much, and thank you, Hillary, for inviting me, and the UIC and the IARC for this important topic. Should multi-cancer early detection tests be considered for use in low middle-income countries? And there is no relevant conflict of interest related to this presentation. And we know that there is a different characteristic between the high-income and low-middle-income countries. Most of low-middle-income countries have the cancer presented in younger population with cancer late stage, more mortalities in spite some lower incidence, the cancer early onset like breast cancer, and also, unfortunately, limited presentation in the cancer research and the clinical trials. So we want to join the new trial with the NIH. And also there is a different genetic, environmental, and cultural disparities, and the high burden of co-infected diseases, co-infected cancer like cervical cancer with human papillomavirus and other diseases, also the hepatocellular carcinoma with hepatitis C and hepatitis B viruses. And because of this extrapolation of the experiences in the cancer control program or even the screening facilities not be considered or not appropriate to be extrapolated from the high-income countries to the low-middle-income countries. And the screening program must be acceptable, equitable and accessible and sustainable and economically efficient to the target population. And also, which is very, very important, the healthcare infrastructure must be equipped to manage the increased case finding with respect to treatment, support, and the follow-up. The WHO emerging screening criteria weighing between the harm and benefit, with the harm showing the diverting the health resources for this screening test and the overdiagnosis, false positive and false negative results, while the benefits including reducing mortality, reducing incidence, and reducing the severity or lowering the stage and increasing the choice. So it is important to go for setting the priorities in the low-middle income countries and trying to find what is the most important cancer to go for early detection programs. So we find that like the 5 main cancer subtypes, which including about 50% of the cancer-related deaths, including breast cancer, colon cancer, liver cancer, cervical, and the prostate cancer. So we are going for initiative for these very important types. Going to the scientific evidence and world evidence, and we hear from Hilary a very important harm and benefit for this multi-cancer early detection test, with the benefits that being very low incidence for both false positive results and accordingly decrease the cost of post-diagnostic investigation, but screening for more than one disease and one cancer subtypes. But on the other hand, there is the overall sensitivity for cancer signals was only 51.5%, and there is no reliable for survival benefit till now. And here is the Global Breast Cancer Initiative and the application in the presidential initiative in Egypt. And this is more or less total solution or holistic activities, not only screening, but also the early detection, proper diagnosis, and the proper management. So the mortality is the most important outcome. So it is outcome-based activity, reducing the global breast cancer mortality by 2.5% per year, reaching 25% in the year 2030 and 40% at the year 2040. Here are the numbers we achieved in the presidential initiative of women health in Egypt, with, as you see, a huge women screened like more than 22 million, with total visits 52 million visits, total examination in the hospitals more than 700,000, total radiology examination more than 370,000, total pathology examination 42,000, and confirmed cases for breast cancer almost 30,000 cases. And really proud that we're converting the advanced stage from 70% before the initiative in 2019 to only 20% now in the stage 3 and 4, and decreasing time for diagnosis from more than 120 days to only 41 days full diagnosis of the patient or the woman, and also all the patients included in the multidisciplinary team approach is mandatory, and also it is audited multidisciplinary sessions. And here, what comparison is like, small comparison between the conventional screening method and the multi-early detection test. And here is the campaign total cost. The total cost of the campaign in Egypt with the presidential initiative is about like $500 million, including the capacity building, including the screening, including the treatment and diagnosis, while the cost subjected to the test itself is more than $20 billion. The diagnosis usually within, the whole diagnosis usually within 49 days, while the diagnosis in the multi-cancer early detection test is almost 79 days or more. And we have to have decreasing the morbidity and the mortality, and in the other hand, there is no survival benefit yet. Another very important example also in the cervical cancer, when we see also again the holistic or the outcome-based an initiative of the WHO with 90-70-90 protocol, and by the WHO statement, we can go for like 74 million new cases of cervical cancer can be averted, and more than 62 million deaths can be avoided by 2120 by reaching the elimination goal. And when you compare that, you find the human papillomavirus test with average $10 per test compared to the huge cost of the MCD test. It is very, very huge difference. And also, we go for, in the low middle income countries, we find patients less than 50 years of age, from 35 to 45 years old, and all the clinical trials of the multi-cancer detector is more than 50 years. And also the sensitivity of the multi-cancer early detection test in the cervical cancer more than 80%, while in HPV screening test is 94% with this very, very low cost. There is no obvious data also again in the multi-cancer early detection test for cross-positivity with co-infection or higher viral load, so it is very important also to go for searching for this. So the way to go for the low middle income countries, very importantly to include it in global clinical trials. So it is important not to include only the high income countries, but it's very important to include the low middle income countries from different parts, North Africa, Sub-Saharan Africa, Middle East. And also younger patients must be included to assess the early onset of these subtypes. We can use it in the other type that we don't have a conventional methodology on screening and the early detection. And also it is very important, if you want to use it, to go for capacity building, is genomic assessment and others, and also data analysis in different countries to be ready for this important test. And at the end, thank you very much, and we are ready for the questions.
Okay. Well, hi, everyone. I'm going to try to be brief because so we can have more time for questions. I do want to thank Hillary for the invitation and for giving me a hot topic to address, although this whole area is quite the hot topic. Let me just say that it's very hard to do justice to this title in 10 minutes. So please hold on to your questions, and hopefully we can do more than the time that we have. So I'm going to take us through this kind of sequence, this story. The first question is, how are we going to evaluate multi-cancer tests? Well, how have we always evaluated cancer screening tests? I won't spend very much time on this, but I'll take a little deeper dive. How well has it worked in the sense of identifying those cancer screening technologies that we really should be taking to the population? Do we need a new paradigm for multi-cancer tests? If so, what might we do differently? And will that work? But I won't quite get to the end of this. We'll possibly end with more questions than answers. So how have we always evaluated cancer screening tests? This is supposed to be a stone wall to show that this written over here in white has basically been set in stone for the cancer screening field for decades now. We evaluate cancer screening tests via randomized screening trials comparing cancer-specific mortality from randomization in screen versus control groups. Why? Well, first of all, the defining goal of screening is it's a preventive intervention. It's designed to prevent deaths from cancer. Well, if we want to look at deaths from cancer, maybe we might want to look at survival, but there were old papers that do a really great job of explaining why we don't want to look at survival, because it's a biased endpoint. There's also a collection of papers proposing that instead of looking at cancer mortality, we look at all-cause mortality, but that is not a sensitive endpoint if you really want to prevent deaths from cancer, if you want to see if you're able to do that. Because typically, except for lung cancer, mortality events are far fewer than all-cause mortality events. So because of this set-in-stone principle, cancer screening trials are large, lengthy, costly, and very complex. How well has it worked? Well, in some cases, superbly. Here are 2 lung cancer screening trials, both giving us the same message, low-dose CT in the NLST and the Nelson trials. You can see my ticker tape here at the bottom. Kind of imagine you're watching CNN. It's moving along at the bottom. Here we have a high-risk population. We have a short natural history. We have a very sensitive test. We have poor survival without screening. We have very high compliance, and we have effective treatment for early stage. How about prostate cancer? Well, there's a less clear message there. We have the now famous story of the two large prostate cancer screening trials that did not agree. On the left, the ERSPC, which had a 20% reduction in mortality. On the right, the PLCO in the US, ERSPC in Europe. And in the PLCO, this is not the, this was consistent across the many publications, was that there was no difference. The screening group was slightly above, not significantly above the control group in terms of mortality, whereas in the ERSPC, a 20% reduction. And I think here we actually have probably the setting that is likely going to be what we're going to be facing with multi-cancer testing. Let's just note that in these two studies, it was the same screening modality, but with multi-cancer trials, we'll have different modalities across the trials. Trials are looking generally at average risk population, really with a mix of natural histories, but what we know from what Hillary presented is that currently we're talking about modestly sensitive tests. By the way, this disagreement between these trials has been shown largely to be due to variable compliance and high contamination in the US trial, and this reference at the end is some very detailed modeling that our group did to try to reconcile the trials, and we eventually reconciled the trials to show an efficacy of screening versus no screening, which we could not observe in the PLCO trial. So it's a mixed bag in terms of how trials are our gold standard, but what I will say is because of their complexity, and I'm going to come back to this, and because trials are designed to evaluate screening, but of course a lot of other things have to happen, including access to efficacious confirmation testing and treatment, to actually, and compliance with the screening modality and access to treatment, is that the trials, and they're over a long period of time, so people have to be compliant over that period of time. Trials are very complex often to interpret. So, do we need a new paradigm for multi-cancer tests? I'm going to make like I'm in a presidential debate and not actually answer that question, but what I will say is that there is in the field some urgency to make trials, to make a change, to make trials more efficient, to get away from that lengthy, costly approach that has been our go-to and in some ways has been such a challenge. And because of this, because we haven't had that many screening tests to evaluate, we have not had many trials, maybe about 50 trials. Whereas now we're facing a future where we have many more screening tests to evaluate, and we are actually facing this conundrum about whether we stick with what we know and what we can trust, or go forward and think about making changes. So there is a push among some to make a change. I'll come back to the kinds of changes that are being suggested here. In these two publications, the change that is being promoted is to use a shorter-term endpoint, as in the Gallery trial, to use the late-stage incidence, or to use a shorter-term intermediate endpoint rather than mortality. But there are other ideas too, and I want to first start with some new smart design ideas that I think we're going to be seeing more of. So the smart design here that I want to talk about, that was the topic of two papers, just this 2024 papers in JNCI, was to look at mortality, but not to look at deaths among all the participants on the trial, but to leverage the fact that when you have a biomarker-based test, you can collect specimens also on the control group. And then later on, when you do your trial analysis, you test those specimens in the control group. Rather than looking at deaths among all comers, you analyze deaths among test positives. And that's where intended effect comes from. The intended effect of screening is to help those who test positive. So if you look at the deaths among those who test positive, you end up with a great deal more statistical power. And so this second publication that Laurie was on actually quantifies how much you can reduce the needed sample size in a trial if you use this kind of design and analysis. Now, but we also want to have shorter trials. So can we reduce trial durations with this kind of smart design? And it hasn't been explicitly examined, but we have to recognize that a trial evolves organically, and the time to observe a mortality reduction actually is cancer dependent because it depends on natural history, depends on test performance, and it depends on the baseline mortality in the control group. So in the prostate trial in Europe, the mortality benefit started to become apparent around 6 to 7 years, whereas in the Nelson trial of lung cancer screening, it only took 2 to 3 years. Very different cancers, very different test performance. So there's no way to preemptively across cancers, and remember that multi-cancer tests are multiple cancers across multiple natural histories, many of which we don't know yet. No clear way to reduce the duration with this kind of design. So we cannot avoid looking at the proposal to use shorter-term endpoints, and this was when the Gallery trial was announced. In fact, I will say that this is, even though the field, as you will see, is in major discussions about short-term endpoints, and I'll try to, in the next few slides, give you a snapshot of the discussion, it is going to be forced on us. We are going to be seeing a trial, and we are going to see a report out of late-stage incidents. And we should know what we're going to do with that and how we're going to prepare for that. Because it's not precedented, it has not been a primary endpoint. Late-stage reduction does not equal mortality reduction. This is the ERSPC again, paper where they looked at late-stage reduction on the left, in screening versus control, 50%. On the right, though, the mortality reduction was 20%. They're not the same thing. You cannot expect to get the same reduction in mortality that you get from late-stage incidents, and it's because even if you shift cases earlier, we know that some deaths come from early-stage cases, so there are going to be deaths from those cases. You're not curing them, necessarily. Late-stage reduction also does not reliably predict mortality reduction based on historical trials. We do not have great correlations across cancers. This is 2 graphs from Hillary's team's publication, where they looked at late-stage reductions on the horizontal axis and mortality reductions on the vertical axis with different types of cancers, and saw that the correlation between the two was very different. Anyway, trials, there are not many trials. Trials can be very different from one another, so even if you saw a reasonable correlation in historical trials, doesn't necessarily mean you'll see the same correlation in newer trials and certainly across multi-cancer tests. So what if we do something more thoughtful, instead of just using a line to predict from late-stage incidence to mortality? And I don't mean thoughtful as a compliment, I mean thinking more about how you're going to do the prediction. It's a little bit more, thinking more a little bit. So let me just explain what I mean by this, and then I explain the graphic. Am I running out of time? Okay. So if you use a model to predict reductions in mortality, where you take late-stage cases that are now shifted out of late stage and you assign them an early-stage survival, and you predict mortality reductions that way, well, it doesn't always work. If you look at the X and the O, that's what I just want to point out on each of these graphs. The X is the observed mortality. The O is the predicted mortality for a given late-stage reduction in each of these trials. And you can see that they're not always on top of each other. But this is a very simple model. It's a very simple model. It does not consider disease subtypes, for example. You might see a big late-stage reduction, but it might be in the slower-growing cancers. You need to take that into account. So we've been modeling this by subtype. So this is one paper and the other. There's a sequel that looks at it by subtype. Okay, let me end with a provocative thought. Given that we know we cannot easily just use late stage for mortality reduction. We can't easily predict from late stage to mortality reduction. My provocative thought is, what if we actually recognized that early detection is, even though we say it is designed to prevent mortality, it actually is only able to move cancer diagnosis earlier, and we need more things to happen for mortality, for it to translate to reduction in mortality. And this is actually a problem because different settings have very different treatment availability. This is a problem. If we have a benefit of screening on mortality in a high-income country, that will not necessarily easily translate to a lower middle-income country. Our screening trials are not portable because we have focused on mortality. So what if we focus on late-stage incidence? And then later, look at our different settings and see whether we can translate that to mortality. This will lead to difficult, but maybe more honest conversations. 2 examples. We have evidence, talking to a patient, your conversations with patients, this test can detect your cancer earlier, but we can't guarantee it will save your life or it will extend your survival. Or maybe we get activists and we say, we're not going to give this test unless we can assure that we can also give our patients access to the treatment that they will need and to the downstream care. And I'm going to leave this complicated explaining the slide, but I just want to say that I said a couple of minutes ago, we are having this forced on us. We are going to get a late-stage reduction out of the Gallery trial. How the heck are we going to interpret it? I will say that we have an unwritten standard for mortality, that a 20% mortality reduction in cancer screening is meaningful. We can litigate how this happened, but 20%, that's what trials are typically powered for, screening trials. But what's a good enough mortality, late-stage reduction? It turns out it's going to be very cancer-dependent, probably cancer subtype-dependent. If the Gallery trial produces a 15% late-stage reduction, is that going to be meaningful? Maybe it's all going to be lung cancer. There's a lot of things to think about if we're getting this forced on us and how we're going to deal with it. And we're excited to do it. So I'm going to end by just saying that we're in the middle of a foundational conversation about how to move forward. And this takes us to the heart of what we can reasonably expect a screening test to do. And I mean, feel so privileged to be a part of it. I don't have the answers. Hillary has a great paper that's a very important point in the conversation. I wanted to give her a shout out, and thank you for your attention.
Can we have a mobile mic, please?
I'm going to grab my water.
It's on the seat. Okay, perfect. All right. We have hopefully 3 extra minutes that we lost at the beginning, but still we'll just have a couple of minutes here at the end. So I think instead of taking questions, I'm going to ask each of you to answer the same question. So in the session that was in this room just before the UICC President's session, we talked a bit about the 10-year view. So comparing 10 years ago to now, what have we really achieved in cancer control? And there was a bit of negativity. What have we really accomplished? So instead, I'm going to ask each of you to look into the future. I'll answer the question for myself first to give you 1 minute to think. If you look 10 years ahead, or you can choose 15 if it really helps you, 10, 15 years ahead in the field of multi-cancer early detection, what is the best case scenario that is actually realistic? What would you really hope to see happening in 10 to 15 years? And I think and try to be brief, as my brief answer to this, I'm going to say that we would see the technology evolve dramatically. We would see the technology of these tests change such that they can really detect early stage cancers, because in cancer screening, reducing cancer mortality by screening, the name of the game is detecting early stage cancers, and I don't think we're there with the technology that we have. So what I would like to see is tests that can find early stage cancers across different cancer types with a technology that is if not cheap, going to become cheap in the near future. So I'll pass it over to each of you, and then we can conclude.
Okay. We keep talking about the technology for the test. Actually, the problem that we have is that the technology for the confirmation. We are not there with the imaging or the biomarkers that are going to be reliable for confirmation. And I think this has been a huge problem with ovary cancer and the trial that used ultrasound as the triage to biopsy. And I think that we need to learn a lot more about radiology, and we need to really think about that next step and get that. Otherwise, these tests are, you know, they're just not going to be able to realize their potential.
I would say it's even one more step in that we need to correlate those findings with clinical outcomes, a variety of different clinical outcomes in terms of how a positive test is related to different subtypes, what the behavior of those different subtypes are, because we know cancer evolves from different pathways. There are 10 or 12 different pathways. There's no expectation one technology can detect all of them all at the same early stage.
I think like going a step back, and what we need the outcome is maybe prevention first. And if we go for going for this prevention, so we can go for other achievement, which is reduction of the mortality. So I feel that the concept of most of the WHO initiatives, like in cervical cancer, you can go for prevention by vaccination, so we don't have even cancer. So it is very important not to early detect cancer, but also you can go for step backward. So it is important to go for like what we want. So we wanted to prevent first, and then early detect and decreasing the mortality is the second outcome we need. So yes, we can go for the multi-cancer detector test, but as you said, it is important to be accessible for the whole population. It is also not only the test, but also the capacity behind for interpretation. And in these countries, if we go for Sub-Saharan Africa, for the North Africa, for the Middle East, so it is important to go for this capacity. So it is, I think, the most important is to look for what is the outcome we want. I feel that it's important to prevent if we can. Even in colon cancer, like colonoscopy, it is preventable. And in the cervical cancer, we can prevent. Or early detect and decreasing the mortality, as in the Global Breast Cancer Initiative. It is not only early detection, but good diagnosis and management. So it is important to have the whole scope and the whole benefit from any strategy we want.
I'm just thinking about that timeline from the perspective of lung cancer screening. So as a pulmonologist, I can remember probably that 10 or 15 year window. That's when I started my training, and somebody brought to the Journal Club research meeting, oh, there's this great study from the US called the National Lung Screening Trial, and it's taken us this long to roll that out. So I guess it's quite interesting to see this effective rollout before we now have the evidence for MSED. So I guess that's helpful. We're starting the story more quickly, but I think it'd be great to sort of see, can we get the research to kind of keep up so we can actually deploy this in the next few years, but perhaps that won't be possible.
Thanks very much to each of you, and I wish you all an excellent conference. Thank you.